afternoon, everyone. My name is Angela Hobson, and I am the Assistant Dean for Public Health here at the Brown School. And it is my distinct pleasure to welcome you to our next installment today of our Public Health Speaker Series at the Brown School. And I get the distinct pleasure of introducing our speaker. Before I introduce her, just a quick reminder that Dr. Carter will give her talk, and then we'll have time for questions and answers at the end. You can put your questions in the chat if you so like, or at the end you can come off mute and ask your question live as well. So with that, I would like to go ahead and introduce our distinguished speaker for today. Dr. Ebony Carter is an assistant professor at Washington University School of Medicine. She practices maternal fetal medicine and serves as the chief of the Division of Clinical Research in the Department of Obstetrics and Gynecology. Her research focuses on evidence-based prenatal care and community-based participatory research to reduce economic and racial health disparities. Her research is funded by the Robert Wood Johnson Foundation, National Institute for Child Health and Human Development, National Institute of Mental Health, and the American Diabetes Association. Dr. Carter earned her undergraduate degree in human biology with honors from Stanford University, her Master of Public Health, yay, in health policy from the University of Michigan, and medical degree from Duke University. She completed residency in obstetrics and gynecology at the Harvard Integrated Program at Brigham and Women's Massachusetts General Hospitals, and fellowship training in maternal fetal medicine at Washington University School of Medicine. And today she is spending her time with us. She's going to be talking about work offering a pragmatic approach to improving outcomes for Black birthing people in St. Louis and their babies. And please help me welcoming and thanking Dr. Carter for being here and sharing her time and expertise with us.
Thank you so much for that very kind introduction, and thank you for inviting me to spend time with you. So I'm already filled with joy seeing so many friends in the blocks. Thank you. It helps to see faces versus talking to a black screen. So thanks to all of you who are doing that. And I am looking at all of you thinking about the fact that it was 20 years ago, oh my gosh, I'm getting old, that I was a first year MPH student at the University of Michigan because public health was my first love. I made that decision before I made the decision to go to medical school, actually. So great to be with all of you today. So this is my official title, but my unofficial title is What's Wrong? And what are we trying to do to fix it? And so I, like many people, started my early career in research focusing on the patient. And a lot of the work that I did was very, very patient focused. But the thing is, we have failed to move the needle in meaningful ways to address health equity. And why is that? And I am going to argue today it's because we are asking the wrong questions and looking at the wrong people. So the issue is not just the patient. We need to look at the circumstances surrounding that patient if we're ever going to make meaningful change. I have no financial disclosures, but I do have shared work disclosures. So a lot of the work that you will hear is based on the work of all of these organizations and community collaborators. These are people who were patients who are now turned really advocates, and they have the most important voice in the room as we're doing this work. So I'm gonna get to what we're doing in St. Louis towards the end of the talk. You will have access to all of these slides, and there are huge swatches of slides that I'm gonna skip over because I want you to have the reference documents, but I'm not gonna spend a lot of time on them. So our objective today is to talk about how group prenatal care models can be applied to address health equity. And then this is just a brief outline of what we're gonna go through to get there. But first, a quote. In the shadow of our finest medical facilities, where kings, queens, and shahs travel thousands of miles for the best medical care in the world, Black babies and mothers continue to die. And I first heard this quote in the early 1980s, and the person delivering it was my mother. I was about 5 years old, and she was the executive director of the Ohio Commission on Minority Health. And she did a lot of advocacy work and traveled the state of Ohio giving talks. And the model in Ohio was ultimately replicated in 38 states. But when I heard my mom deliver these words as a little kid, she gave me some of my earliest lessons in health disparities. And she was talking about it at a time when no one else was. It was her life's work to make sure that those words did not ring true. And I could have never imagined that 40 years later, I would be standing here in one of these fine medical institutions of which she spoke, delivering babies, and her words would ring as true today as they did back then, despite the fact it was her life's work to make sure they did not. So she and many like hers did a phenomenal job of defining the problem. And I think you are hard pressed to find anyone argue that there's not an issue, there's not a problem. But like I alluded to in my second slide, the solutions have been extremely elusive. So this is a picture of where I work now at Barnes Jewish Hospital. And this is a map of the St. Louis metro area and the preterm birth kind of heat map. And so it's looking at preterm births per 1,000. And so you can see like the darker the color, the higher the preterm birth rate. And is there any accident where you see red? And who lives in those red spaces? And this is not by accident. And so I'm going to get back to this by the end of the talk. But this kind of shows some of my community partners and where we're located and why we're located there. So briefly, in terms of the epidemiology, this has really caught fire in the lay press. So everybody knows it. And so I'm really happy that we're not arguing like my mom was in the 80s, that there's actually a problem. But behind all of these statistics are real people, and people are terrified. So as a high-risk obstetrician, I have patients that are driving hours to see me because they want to see a Black physician to care for them. And they are terrified that they're going to die either in pregnancy or in childbirth, because they're seeing all of these things that are, all of these things in the lay press talking about the maternal mortality rate. And so it is really hard as a Black high-risk OBGYN to care for patients who, in which should be one of the most joyous times in life, people are petrified of death. And so along with several other midwives, obstetricians, birth workers, we actually wrote this article in the St. Louis American earlier this year, and it was called A Love Letter to Black Birthing People from Black Birth Workers, Midwives, and Physicians, acknowledging that people are justifiably scared. And while at a population level, the risk is horrific, at an individual level, most people actually do extremely well. So we kind of towed this like very delicate line saying, yes, there's a serious problem, but for you personally, we encourage you to like reclaim the joy that should come with this experience, because your absolute personal risk is actually not magnified as high. It was a hard line to toe there. So this is a chart from one of the committee opinions from the American College of OBGYN. And it just shows, I'm going to talk about obstetrics because that's what I do, but across the board, when you look at reproductive health outcomes, and this isn't just a Black-white issue, we can look at the multiple levels of diversity and issues of equity, right? But across the board, there are disparities. There's an issue. And that's actually all I'm going to say about it, because I think that within this audience, like, I don't have to prove that point. We know it's an issue. Across these adverse pregnancy outcomes, though, that we know, there are common risk factors, which I have listed here. And in particular, IUGR stands for intrauterine growth restriction. So when a baby is growing really small on the inside, preterm birth is a birth before 37 weeks. We all know what a stillbirth is. Preeclampsia, HELP, all of these complications of pregnancy, which can be potentially catastrophic for both the patient and for the baby, have long-term consequences over life. And so I want you just to imagine with me, humor me with this graph for a second. I'm going somewhere with it. If on the x-axis, you have on the bottom healthy and then some disease threshold, if you go over that disease threshold, then let's say it's diabetes. So everybody has some insulin resistance while they're pregnant. So if we say that this is diabetes, you start over here, you're born, you get to your reproductive years, you get pregnant. Hopefully you were healthy, and so you don't cross this threshold of getting diabetes of pregnancy. And then you end with that metabolic hit after pregnancy, you go back to normal, live your nice, happy life, and you never have diabetes. But there's a subset of patients, and these are the patients that I largely serve, who are predominantly Black women living in North St. Louis City and County who have horrific health outcomes. Let's say that your mom had gestational diabetes. So before you're even born, you've already taken a metabolic hit. And then you hit your reproductive years, you get pregnant, and because you already have some other issues going on, you do cross that threshold of disease, but you're young, you're relatively healthy still. So after you have the baby, you go back to normal. But then type 2 diabetes is just around the corner. And I'm not talking like 20 years down the line. Within 5 years of having a pregnancy complicated by gestational diabetes, the risk of type 2 diabetes is as high as 70%. So pregnancy is a window to your future health. It's not about like just that one bad thing that happened in your pregnancy. If you have any of the outcomes that I talked about in the last slide, your risk of having future cardiovascular disease, heart attack, stroke is increased by 2 to 3-fold. So there are lifelong implications for both the patient and the baby to having these adverse pregnancy complications. And really my life's work is to try to push patients who are on this red line back down towards the black line. So with my diabetes example, maybe they don't get gestational diabetes, or if they do, we use that as a window, do risk reduction strategies, and they either never get type 2 diabetes or they get it when they're 80 and not when they're 50. So before we go any further, I want to ask you all a few questions. And the questions center around, are all health differences unfair? So a few hypothetical situations. If I told you that football players have more arm and leg fractures than people who don't play football, you have a problem with that? What if I told you that wealthy people have higher rates of an illness than poor people? Is that problematic? Or that younger adults are generally healthier than the elderly? Or what if men have a shorter life expectancy than women? Are any of those scenarios problematic to us? So a few definitions. I want to start back with the Institute of Medicine, now called the National Academy of Medicine's definition of health disparities. I'm going to blow through these because I think you guys probably already know these, but I think that this graphic is helpful because what is the difference between a difference and a disparity? And so here, if we have this kind of arbitrary quality of healthcare measure here, and here we have non-minoritized communities versus minoritized communities, the delta here is the difference, but what goes into that difference? Okay, so there could be clinical appropriateness and need. So let's say that I'm rounding in the intensive care unit and there's a patient that says, I don't want to live like this. Like if I need to be on a ventilator and have all of these things, then just forget it. Like I don't want to be bothered with that. Well, that's appropriate. That's a person's choice and they can choose to do that. And there's other patients that are like, I want everything done, and that's appropriate. So if there's a difference in mortality between those two groups, I would argue that that's a difference and people are entitled to that. But what if the changes are because of the way that the healthcare system operates or the way that the legal system operates? What if it has to do with discrimination? So I would argue that those things equate to disparities versus the clinical appropriateness or what each of us value personally is a difference. That's not the part that we're worried about here. We're worried about the disparity. So this is an enhanced IOM definition, and they take it a step further to say that observed clinically and statistically significant differences in health outcomes or healthcare use between socially distinct, vulnerable, and less vulnerable populations. And I invite you to think about those kind of hypothetical scenarios I gave you there when we framed this definition. And then finally, when we go to the Healthy People 2020 definition, a particular type of health difference that is closely linked with economic, social, or environmental disadvantage. They affect people who have systematically experienced greater social or economic obstacles to health based on their racial or ethnic group. And I'll let you read the rest of this yourself. But I think about giving a similar talk to this a couple of years ago in Arizona. And a physician came up to me who worked on a reservation and said, you know what? I experience reverse discrimination because I try to take really good care of my patients and they come in automatically thinking that I'm trying to harm them. And he just goes off on a tirade. And I was thinking, I have just wasted my breath. Like you didn't hear anything that I said, because there is a power dynamic. As the clinician, you have the power in that scenario. And so he was in an infinitely greater position to inflict harm on the patients he was serving than they were to him. So I'm like, I'm not particularly worried about you, honestly. It's not about you. You have to think about the power dynamic as you're doing this work. And so the fact of the matter is that some of us face greater obstacles to health. And how do we start to change that narrative so that we all have an equal opportunity to have a healthy life and a healthy outcome? And so moving from disparities definitions to equity, what is health equity? Health equity means that all of us have a fair and a just opportunity to be as healthy as possible. And that means removing those obstacles that you saw in the cartoon that I just had. And so now for a conceptual framework. I alluded to this in the first slide, and I used this graphic in a grant that I wrote. But patients don't live in a vacuum. They live in communities, right? So you have the patient, you have the clinician, you have what happens between them, which is the clinical encounter, and then you have the healthcare system around them. And then I would argue, I put my little graphic here, that you have the healthcare system, but around that you have the social and the physical and the built environment. And you have to think at all of those levels if you're going to impact change. And I think where we have fallen short in medicine, and where I think public health has been a bit better than us, is in looking at the multi levels. So I'm going to breeze through these slides, and they're here so that you have them as a reference. You can see the citations, but does anything protect you? And I'm going to deal predominantly with the issue of race, fully recognizing that there are multiple dimensions of diversity that we should be paying attention to. So in particular for Black patients, because that's who I predominantly serve, nothing protects you, right? Like, not your economic status. I'm a high-risk obstetrician and I've had a preterm birth. Like, nothing protects you. And so why are these outcomes happening? Stress has emerged in recent years. I remember in my early years of practice, patients would be like, oh my gosh, I'm so stressed out. Is that going to impact my baby? And I'd be like, oh no, you're fine. I mean, it doesn't help to say, yeah, it's going to impact your baby, but there is emerging evidence that stress is not a good thing. And if you are in a minoritized community, do you have differential levels of stress? Have you dealt with different levels of racism and adversity and all of those things in your life? And the literature is emerging to be pretty compelling that the answer to those questions is yes. So I'm going to ask you all, as I kind of fly through these rest of these slides, to like get a piece of paper out, because I'm going to ask you to do something in a second. But this is an interesting study that was by Paula Braverman that essentially said that patients who even worried about being discriminated against had worse pregnancy outcomes. So there are really real impacts to racism. And I stole this slide from Joya Creer-Perry from the National Birth Equity Collaborative. And so we talk about social determinants of health a ton ad nauseum, but social determinants of health didn't just like pop up and become a problem on their own. What's contributing to it? And the fact is that there are structural issues at play that contribute to the social determinants of health. And then what are the root causes of those kind of structural things that are happening? It's really discrimination and racism. And so I love this because I feel like we often start our conversation at the social determinants of health, and we don't think about what were the factors that led up to it before then. And then this is just to go into racism as a root cause, and it occurs at multiple levels, which I'm not going to go into completely today. But I do want to take a little mental break and ask you to pull out that piece of paper. So in the next minute or so, I want you to write down the initials of the 6 people who you trust the most in the world who are not your family members. Okay, these are your ride or dies. Like, they're not going to judge you. They love you. You can go to them. So initials of 6 people in your life who always have your back. I'm going to give you just a minute to do that. I'm going to give you about 10 more seconds to wrap that up. So the second part of this activity is I'm going to read out some dimensions, and I want you to put a tick mark next to each person on your list who matches the dimension that I'm about to say. So how many of the people on your list have the same nationality as you? And just go ahead and put a check mark. And what about the same native language? Age, kind of roughly age group. Race or ethnicity. Professional background or educational status. Religion. I could keep going, but I'll stop there. So would anybody be willing to share kind of what if they see any patterns on their list?
I can share.
Yes, please do.
So I actually only came up with 4 people because it's early in California right now. But in general, I found that the tick marks showed that the people I trust the most, I guess, they shared a lot of tick marks with me and each other. A lot of the things you listed were common between all of us.
Thank you. Thank you, Lillian, for sharing that. Does anybody else want to share? Did anybody else have a different experience in that? Or nod your head if your experience was fairly similar to Lillian's.
It was similar. In the 6x6 table of people and factors, there's only 6 boxes that are empty of check marks.
Thank you. A very nice quantitative way of looking at that. I appreciate it. Anyone else want to share?
I could share, but it's kind of similar to Lillian because I only had 4 people and only one of them had nothing in common. The rest of the 3 had everything in common. So kind of similar.
I've done this exercise a lot, and I feel like 95% of people tend to say exactly what you and Lillian said, which is that the people who we trust the most in life tend to have a lot of things in common with us. And the tendency or preference for people who are like ourselves is called affinity or in-group bias. And the fact of the matter is that we all have it, that over life, we are all socialized to kind of have these biases. And I think the word bias instantly has like this like negative association with it. But the fact of the matter is that bias is sometimes good. So I'm a physician, and in my medical training, I remember I would get paged to the emergency room for a hemorrhage. And when I was a brand new intern, when I would get that page, my heart would start beating really quickly and I wouldn't want to go. Because I'm like, I don't know what to do with a person hemorrhaging. And so I would walk. I did not run. I walked, praying that somebody would get there before I did, because I didn't know what the heck I was doing, right? And then around February of my intern year, I caught myself getting that page and running. And I was like, wait, why am I running today? And it's because I knew what to do finally. In medicine, there are these emergency situations that happen regularly. And so when you think back to like your intern year or the last hemorrhage you had or whatever else, you make these mental shortcuts to be able to quickly make decisions that if you took the time to analytically think through each thing, the patient would have bled to death by the time you got through all of that. So these biases that are formed through prior experiences can actually be quite powerful and quite good in a lot of ways, but we also have to realize that they have the potential for harm. And that we have explicit bias, that it's like, you know, the guy from the KKK and like the Klan hat, right? And I think that most of us are like, oh, that's not me. But I did that exercise so that we could realize that we all have these kind of preferences for people who are like us. And these can come in many different flavors. Here's my little Klan hat example. And this was one of the earlier studies. I remember Kevin, I forget his last name, from the VA in Durham, did the first version of this study, but where you go to a conference, you give physicians different clinical scenarios, and all you change is the, whether it's Black or white, and in terms like the gender of the people who are reading the scenarios. And without fail, the patients who identified as women more often did not get the right treatment, and the patients who identified as Black more often did not get the right treatment. And this was like the first time that in medicine people started to say like, oh my gosh, maybe something is really happening. But even if you realized it was happening within the system, for us personally, it was always like, oh, but that's not me. So I remember doing a domestic exchange program at Spelman College and doing an epidemiology course with a professor who I respected a great deal. He was a Black epidemiologist. He worked at the CDC, and he shared that during his PhD studies, he had actually spent several months in Tuskegee working on the Tuskegee experiment. And he said that he had actually been there for about 3 months before it ever occurred to him that something did not seem quite right there. And his point in telling us this, my professor, who I had a great deal of respect for, he seemed to have like a great moral compass and seemed ethical and all of those other things. What he said to us is those of us who think that we're most immune to ethical dilemmas are most likely to fall victim to them. None of us are immune. We all can slip and not realize it, because there were actually some things about the Tuskegee study that were done extremely well. And when it started, it was not unethical. It only became unethical when penicillin was developed and they didn't give people the treatment, but it actually didn't start off being an unethical study. And so I call all of us to kind of that higher standard and that higher level of thinking, realizing that all of us are prone to fall into these situations, even though none of us woke up this morning deciding like, oh, I think I'll be racist today. So I want to spend the rest of the time thinking about potential solutions, and I do not proclaim to have the solutions. I'm going to tell you what we're working on this little teeny tiny corner of the world in St. Louis to try to address these issues for the patients that I serve here. So where do we go from here? I think the life course perspective is really important. As a high-risk obstetrician, I can kind of have this like laser vision on pregnancy, but good pregnancy outcomes happen before and after pregnancy, right? Like if you have terribly controlled diabetes and you come to me when you're 12 weeks pregnant, all the baby's organs are formed already, and there's not a whole lot I can do at that point. Like good pre-pregnancy care is actually key. And then postpartum care is really care for the rest of your life, or it's care for before the next pregnancy. So on that little graph that I showed, I actually would argue that the most important times are actually in between, even though our government and Medicaid acts like the only time that people deserve healthcare is like when they're pregnant. I won't get on that tirade. We also need to target the likely causes, like the social determinants and bias and racism. I'm not going to get into this much here, but for OBGYN, perinatal quality collaboratives have been really important in improving outcomes. Missouri is very behind the times, and we're one of the last states to adopt this model, but this has actually been very promising. California's done an amazing job. And then support evidence-based interventions, and group care is the one that I'm focusing on. So briefly, in terms of group care, can you just nod your heads if you've heard of group prenatal care or centering pregnancy before, or is this a totally foreign concept? I see like 50-50, so I'll talk about it briefly. It was started in the 1990s by a midwife named Sharon Schindler Rising, and she believed that the power and the knowledge came from the patients, not just the clinician. And so essentially, groups of patients around the similar gestational age get all of their prenatal care together in a group setting. So picture this. You are newly pregnant, you come into the clinic. Normally you sit and wait in the waiting room for like 20 minutes for your visit. If you're in group, you come in, you check in, you go right to the group space, you get some snacks, you check your own blood pressure, you check your own weight. So if I have a patient coming into our labor emergency room who has been in group and I say, hey, what if your blood pressure's been running? They can tell me like this because they know they've been checking them themselves, versus most patients have like no idea of what their numbers are. Each patient after they do that has like a very quick thing called mat time. It's because they used to do it on a mat, but here at Barnes, this is where we do our mat time. So for about 3 minutes, the clinician talks just to the patient, checks the baby's heart rate, sees if there's anything particular to your pregnancy you want to talk about. So if a patient's like, oh, I feel this like pulling sensation sometimes when I get up in my groin, then I can say, you know what? I bet somebody else in the group is having that same sensation. Do you mind if we take that to the group? And usually they say yes, and that's what we do. So as a clinician, it's lovely because I'm not saying the same thing 20 times all day. You can actually take most of the stuff to the group. And when we get to the group, the patient who's having her fourth kid is like, oh girl, that's that round ligament pain. I had that with my second baby. And I don't have to say a word. The knowledge, the wisdom, and the power, if you do it right, is coming from the group. So after you do mat time, and we're in a big room, I usually have some jazz playing in the background. So that is the privacy screen. We have this little screen here for a little bit of privacy. But after that, we go to the other side of the screen. Everybody is sitting in a circle, kind of like you see here. And for the next 90 minutes or so, we do a fun, interactive, kind of adult learning principle-driven curriculum. And I always have an idea of what we're going to talk about for the group. And it's stuff that you never have time to do in normal prenatal care. Like you don't have time to talk about things like, the baby, like, how are you going to care for the baby? How do you know that a baby is hungry? I mean, the first time I attended a group, my oldest child was 4 months old, and they were talking about signs of hunger, and crying is a late one. Like by the time they get to crying, they are hot and you have missed so many marks. And I'm like, oh, I wish I had this before I had a baby. So, I mean, I have found much value in these groups. And so anyway, the reason that I got interested in group in the first place, this is another picture of our group and kind of a model of the curriculum, which you can throw out the window. If patients come in and there's something else on their heart, forget the curriculum. What's more important is you go where the group needs you to go that day. But the reason that I even got interested in group care was because of this trial from 2007 by Genetics. And so it was done at Emory and at Yale. It was a randomized trial of predominantly Black patients in New Haven and Atlanta. And what they found is that patients who were randomized to a group had a significantly reduced risk of preterm birth. So that caught my attention. But when you did a subgroup analysis by race, you look at Black patients and the difference or the disparity shrunk. So that essentially the disparity disappeared because the differential in preterm birth rate was even greater for patients who were Black. So the reason this caught my attention, it's like one of the few interventions that I've actually seen that has a reasonable effect size. And this rivaled the best treatment we had for preterm birth in the day, which was 17-hydroxyprogesterone, had about a 33% risk reduction for preterm birth at the time. And this approached that medication. So that's actually why I got interested in this in the first place. And these are some other notable findings from that trial. We followed it up because the quality of evidence for group care wasn't that great. So we did a meta-analysis here at WashU. And I got hate mail after publishing this meta-analysis because guess what we found? There was no difference. There was no, once you actually control for the quality of the studies and those kinds of things, the difference disappeared. There wasn't one. But when we did the subgroup analysis, once again for Black patients, the effect size came back. And so why is this? And I would argue that everybody really loves group care, but it tends to move the needle for those among us who are most likely to have a bad outcome in the first place. So if you are wealthy and affluent and have everything in the world going for you and you participate in group, you'll love it, but you would have been fine anyway. It's those people who actually are going to have a bad outcome who probably benefit the most. And so in response to all the hate mail I got from this article, my mentor wrote this line: "We reported our findings dispassionately in favor of our role as scientists rather than our enthusiasm as practitioners." And so my opinion, everyone likes it, but some groups are going to benefit more from it. So why? Why is group care working? And this is a paper that looked at, does it matter more that you're following the content, that you're actually hitting every single thing in the curriculum, or is it the process? And what do you think they found? Process matters over content each and every single day. This is a qualitative paper that looked at shared medical appointments. We call it group care in pregnancy, but outside of pregnancy, shared medical appointments, there's a huge literature around it. And I think that what's really interesting is if you look at the different mechanisms that they propose, roughly half of them focus on the clinician, not the patient. And so we wrote this editorial piece in the American Journal of OBGYN, which is kind of like the top OBGYN journal earlier this year. And the name for this talk today comes from this paper. But we essentially make that argument that we're looking at the wrong people in the wrong places. If you look at Black patients in particular, and we say, oh, we just do this intervention so that they're more educated, or we do this intervention and we change their behavior, then it's all gonna get better. The patient is not the problem. The problem is us. It is the clinicians. It is the systems and the structures in which we're functioning. And so if we keep looking at the patient, we're never gonna find the answer. And in walks kind of where I want to spend the end of our time today, Elevate. And some of the, I see Ty Howe on this call. So some of our partners for Elevate are very much here today. And so I want to give them a shout out. But Elevate stands for Elevating Voices, Addressing Depression, Toxic Stress, and Equity. And this is kind of what we're doing in our little neck of the woods now. I want to center my talk from Elevate in this quote by Reverend Wilson. And it says, programs are short-term interventions that create temporary improvements in the wake of challenges. Policies, on the other hand, are covenants we collectively choose to live by, as articulated in legislation and regulation. They inform our socially accepted mores and ethics. So I want to be very clear that Elevate is not just an intervention, because it's a collaborative of people that are working at multiple levels to affect change. And so in terms of Elevate, to give you a little bit of background, in 2016, all of the group care clinicians, providers in St. Louis City and County got together, and you can see the sites listed here on my trusty little map. And we essentially were talking about the fact that the preterm birth rate for the patients we serve is like 18%. If you look at Western European nations, it hovers more around 4%. If you look at Clayton, it's about 5%. So why is it that just a couple of miles over for the patients I serve, it's 18%? And so that's where our conversation started. And so we really wanted to figure out what could we do to affect change. We realized we couldn't keep doing the same thing the same way and expect a different result. And we didn't have a name then, but that's actually in the basement of Affinity Healthcare on Biddle Street was where Elevate was born. And so all of us were group care clinicians, and I already showed you pretty compelling data that group care does improve outcomes for the patient population we serve. The other frustration a lot of us had was mental health. So it's hard to get mental health services for anyone, but if you're poor, forget it. There was nothing available yet. 80% of the patients we served had a mental health diagnosis, usually depression, sometimes anxiety. 80% of them also had experienced trauma in life, and there was no resource, and most people didn't have access to healthcare outside of pregnancy. And even if we caught to make the referral, there was often no one to refer them to. So how do we take these things together and do something? So those were the initial conversations. We had some fights early on, like, when we present now, it's like kumbaya, look at the Elevate Collaborative, but it was not always like happy and joyous. So one of our fights was, what should the role of research be? Because research is done poorly by our communities historically. And so a lot of people were like, wanted no parts of research and Elevate, but we came to the ultimate conclusion that if we didn't do research, then we would never be able to tell the story of what we did. So whether we failed or whether we were successful, if we didn't do it in a systematic way, then it would die once this effort died. So we actually ended up embracing research. And so my role is not really like the brain or anything else. My role in this is really being the storyteller as the researcher. The other thing is, how do we address the root causes and policies that are driving the inequities? And then what does accountability look like? Like throwing that typical hierarchy of medicine and public health on its head and saying like the WashU, BJ people are not at the top of this pyramid. It is our community collaborators, and they are going to have the loudest voice at the table, and we are going to be driven as a collaborative, but they are actually the most important voice in the room. We also embraced the principles of the Ferguson Commission and really kind of applied this framework to our work. So trusting, acting, and asking. And I have like a little QR code to that report if you're interested. And using a racial equity lens in everything that we did. So as we started to think about like policies and how we would do things, the questions were, who does this benefit? How are different groups going to be affected by the decisions that are being made? And then what are we missing? So the racial equity lens was applied to all of the work. And so what we ended up coming up with is, over the course of about a year, we took the Centering Pregnancy curriculum that is essentially was created largely for middle income suburban white patients. And we took a look at it because a lot of us were centering pregnancy providers to start with. And we decided to kind of like throw that out and start over again using a trauma-informed anti-racism lens, with the idea that basic evidence-based mental health strategies like cognitive behavioral therapy and mindfulness that we were already using under the guise of labor preparation. So kind of like, how are you going to prepare for the discomfort of labor? And so we were already doing yoga and many of these things for labor preparation, but they actually lend themselves really well to enhancing mental health. So we trained obstetricians and midwives and nurse practitioners and all the people who were doing group care at these sites. We trained them in how to do basic evidence-based behavioral health techniques like cognitive behavioral therapy. So we did that training. We did anti-racism training. We did trauma-informed training. And then we did a pilot to see just like, is it feasible? Can we actually do this? So at 3 sites across St. Louis, patients either were in traditional care, they were in Elevate group care, or just standard group care. And my slides have a mind of their own. And then we followed them to see, was there a difference in outcomes? And that's not what we were really looking for. It was just, is it feasible? And if we see something, great, but that was not the purpose. So imagine my surprise when, with only 48 patients in the pilot trial, we saw that patients who participated in Elevate had a 50% decrease in depression. Their C-section rate was lowered significantly. More of them were breastfeeding when they left the hospital. And this was the kicker. For preterm birth, for patients who were in individual care, it was the standard 18% that we always see. How many patients in Elevate had a preterm birth? Not a one. So with our little baby pilot trial, can you believe that there was a significant difference? And I admit that this could be a fluke. It was not a randomized trial. People chose what they were going to get. So there's all kinds of methodologic issues, but it certainly suggested that there might be a there there. These are the qualitative outcomes. So we actually talked to the clinicians and we talked to the patients about their experiences. And I think I have 4 minutes left, so I'm quickly running out of time, but that's there for your reference. Testimony time, and this is for any of you who are interested in pursuing academic careers. I started working with Elevate my first year on the faculty here. And my mentors were very well-meaning because they were saying, Ebony, stay focused. But I was spending a lot of time working with the Elevate Collaborative. And they essentially said to me, this gets you no academic credit, okay? Write your grants, write your papers, stay focused. This is a distraction. And, you know, with your mentors, you listen to the things that are good, and the things that like don't resonate with you, just leave it. Because I kept doing it because in my heart, it felt like it was the right thing to do. Even though it was hard. And sometimes, even being identifying as a Black woman, sometimes I was identified as the man because I represented WashU and BJ. It was hard at times, but we kept going. And it's crazy that Elevate ended up being the first R01 that I got on, not for Ebony, but on behalf of the collaborative. So that's my testimony of like, stay true to what you think actually is impactful and meaningful and is the right thing to do for your community. So we got an R01. And so we are in the process now of randomizing patients to either traditional care or Elevate, and then following them out. Our primary outcome is postpartum depression. We're also looking at preterm birth and low birth weight. The Elevate family has expanded. It's now actually statewide. So we have 8 sites across the state of Missouri, from here to Kansas City, who are doing Elevate. And it's a hybrid implementation effectiveness trial. So we're also looking at like, what are the factors in terms of how you implement it? This is a community-driven project. So the way that Elevate looks at the different sites is different. So here at Barnes, we're doing it for our teen clinic. And the folks here felt very strongly that teens needed access to group. They heavily believe in group. And so they didn't feel comfortable with patients not having access to group. And so at Barnes, the default is that everybody ends up in Elevate, and then we go consent them and say, hey, are you willing to be in this trial? And then they know that it's randomized 2 to 1. So they know they have a 1/3 chance of being randomized back to individual care. At all of the other sites, they're kind of like, we want to get this done. We believe in this. We want to find out the answer to this question. And so the only way you can access Elevate is being in the trial. So we're looking to see, do those little differences between the different sites matter in how Elevate actually plays out and whether or not it's effective. We also are looking at the clinicians. So admittedly, this started just like, you know, I'm as guilty as everybody else. We started off looking at the patients, but the more I do this work, the more that I think that the reason that group care interventions are working, maybe it's working on the patients a little bit. I think by and large, it's driving the behavior of the clinicians. Our ability to change people's implicit biases have been disappointing. You can't change a lifetime of accumulated bias and a 1-day implicit bias training. But I think that Elevate is increasing clinicians' empathy. So that patient who always shows up late and makes me late to pick up my kids from school because they're always late and I'm like mad. When that patient comes to group and I realize that she had to take 3 buses to get to me, and that her partner is not being particularly kind to her right now, and that she just lost her job. Like, when you understand a person as a person, then your empathy goes up for them infinitely. I don't like delivering babies at 2 a.m. I do not go into the hospital to deliver anyone if I can help it, but I'll do it for my group patients because I have a relationship with them. And so is it that relationship that is changing how clinicians show up and how we care for people? And so we're also looking at that. So I'm going to leave you with this quote. My mom, my Shiro, died about a year ago. And one of her mentees actually reminded me that she used to always end her speeches with this quote that I wholeheartedly embrace from Lao Tzu, and I will leave you with it today. Go in search of your people, live with them, learn from them, love them. Start with what they know, build on what they have. But with the best leaders, when the work is done, the task accomplished, the people will say, we have done this ourselves. Thank you to all of you for listening. And I also want to thank my research team and the funders. And with that, I would be happy to take any questions. Thank you.
Thank you so much, Dr. Carter. This was just an amazing talk. So many great things that you talked about here, and congratulations on your R01. That's a true testament. And I love the testimony that you gave behind that about staying true to what we're committed to. So thank you for that as well. So I'm going to open it up for questions. Anyone who would like to take themselves off of mute to come and ask your question live, please do. Otherwise, you can put your question in the chat, and I see Lee, you have your hand up. So please, if you'd like to start us off, that'd be great.
Thank you. Ebony, excellent presentation. So exciting. I think Washington University should feel very fortunate to have you at the campus and leading this body of work. I'm just amazed by the excellent work. And then again, like echoing Angela, congrats on your R1. That's fantastic. So you talked about 8 sites statewide right now. I want to ask you a question about scalability. So obviously this works, and you said it, and the research has been evident. So I want to ask you, what are the key elements if you see this body of work can be adopted at a policy level, can be scaled at other states beyond Missouri to go big? What are the core elements?
Thank you for that question. So one of the issues with group care, and I always want to be careful when I present this, especially to like clinical audiences or community health centers who are thinking about adopting it. I made it sound easy. It's actually hard. The logistics of doing groups it's much easier to be like, okay, I'll see you at 8 o'clock next Tuesday versus having 10 people who all need to come at the same time. And it can be difficult to do. And one of the key things is having a champion. So if people like are forced to do it, it often fails, but having one person in a clinic who is super excited and is like, we're going to do this is often very helpful. The other thing is money talks. So because it is a little bit more difficult to do, like you have to have snacks. Clinics don't have a budget for snacks. Right. And we even have little incentives. We have baby bucks. So every time you come, you get baby bucks, and then you can like get stuff out of the store. So by the end, you could get a car seat or, a stroller. So the grants have allowed us to do all of these extra nice things, but healthcare reimbursement doesn't allow you to do that. So one of the models that I have really embraced that we are trying with Elevate is the state of South Carolina. By no means like a progressive state in most domains, but they actually reimburse differentially for group care. So some of the early group care studies came out of South Carolina showing that like the preterm birth rate was significantly lower for the patient population there. And it saves the state Medicaid program money to avert these preterm births and not pay for these $2 million NICU stays. So they actually pay about $500 more for patients who get their care in group than patients who get it in individual care. So we're in the early stages, right? Like we're doing the R01 efficacy trial for Elevate now, but we have met with like Home State and like the large Medicaid insurers in Missouri to start talking about what are their payment strategies. So that's just one example of what we're doing kind of at a policy level. And then for the actual intervention level, I don't know exactly. It's going to be really interesting. So we have some sites like Affinity that have embraced this model wholeheartedly. They are training their entire obstetric staff in Elevate. So they basically have given their staff the protected time to make sure every single person gets trained. They're the only site that has done that. Everybody else has 2 or 3 people that they either like said, you're doing this, or people who were champions. They're like, we really want to do Elevate. And so it's going to be interesting to see how do these differences between the sites matter and how it rolls out. And then what is the adaptation? So one of the critiques that we got is Elevate was at the end of the day created by Black people for Black people. All of the patient advocates that we have are Black women who came from our sites. So, but it's open to everyone. So it doesn't matter whether you're white, Black, blue, purple, we don't care, come on to Elevate. And the thought behind that is that if you create a program that improves outcomes for those among us who have the worst outcomes, then it's probably actually beneficial to everyone. At the worst, it's probably not going to cause any harm. And so Elevate is actually for everyone. And so of our sites, our sites are about 70% Black in terms of the patient population, but it's about 20% Spanish speaking patients. Affinity has a Spanish speaking site, and it's probably about 10% white. So it will also be interesting to see for those other groups, how does it play out for the Spanish speaking groups? What adaptations end up needing to happen to make it work? And this is very pragmatic. So we're not going into sites saying you must do it this way. It's community focused. So we're actually encouraging sites to make the adaptations they feel need to be made to the curriculum, but we're studying it. We're recording what those things are. So that was my long way of saying, Lee, I don't know, like, hopefully I'll have an answer for you in 5 years.
Thank you so much. And thank you, Lee, for the question. And we have a lot of folks who have raised their hands. I'm just going to go in order and maybe we'll get to everybody. Hopefully we do. But Najwa, I think you were up next. So please. Oh, Najwa, I'm not sure if you're speaking, but we can't hear you.
Can you hear me now?
Yes, we can. Thank you.
Okay, perfect. First and foremost, I want to thank you, Dr. Carter, for your amazing presentation. You know, I love your work. I am a stand for Elevate, but I have a question that really relates to the point that you just made, because I am aware that a lot of the partners that you have for Elevate are community-based organizations. A lot of those who work within this collaborative identify as people of color, specifically Black women, yet and still there's a lot of people who don't share that identity that want to be able to be involved in this work. But at the same time, we also have to acknowledge that it can be traumatic for people who don't share the identity of being a Black woman to participate in work that is meant to elevate our outcomes, to protect us from harm. And so I'm curious to know, what are some of those experiences or exposures that you would suggest women who don't have the identity of being Black women, or anybody who doesn't have the identity of being a Black woman, what are some of the experiences or exposures that they should have prior to joining this work? Like if you were to develop a work description and have a list of qualifications of some of the things that you need to have experience in and skills for and exposure to, what would some of those things include so that when people join this collective and collaborative, they have the skill set that will help the initiative and not serve as a burden to the collective?
No, thank you. I appreciate that question. And I will be very honest in saying that it is an evolving work, right? Because when we started this work 6 years ago with the 6 patients that are still our patient advocates now, that's kind of where we started. Certainly we want to be inclusive, and that is still a work in progress. And it's inclusive both in terms of gender identity. The other thing is we had our Elevate kickoff in April, and we had a panel of former participants who had gone through the program in the pilot study. And I felt convicted during one of those panels because one of the fathers was there too, and essentially said, y'all are great. You've been great for her. And, you know, I'm really appreciative. It was an unintended pregnancy. They were early in their relationship when it happened. They hadn't talked through a lot of the things that you have to like figure out as you're starting a family. And he was saying that Elevate really helped them to have those conversations. But he also felt invisible as a father who was there. So I think that in terms of inclusivity, I don't claim to have all of the answers. We are still very much a work in progress. If you have thoughts and feedback and ideas, I would certainly welcome that. Because I will say that I and the collaborative still are very much working to figure those things out.
Great, thank you. And Camille, we'll go to you next.
All right, Dr. Carter, thank you so much, first of all. That was a great talk. So a lot of my research interests actually are on patient-provider communication and how that amplifies racial and gender disparities, particularly surrounding pain and chronic pain in particular. So a lot of what you talked about really resonated with me, especially because it's so frustrating to, you know, have Geronimus's 1990 whatever paper on weathering and have Green's paper on fractures and differential treatment, you know, and still, you know, then have papers coming out recently showing that medical students have, you know, these implicit biases where they believe that Black individual skin is thicker, you know, and seeing that there really hasn't been that much progress made. And so I've been fortunate enough to be able to give talks to residents on some of these issues and to kind of see that a lot of them don't even realize that it is an issue. And so I know that that's a first step, but I guess my question is the part about the empathy building with physicians was really interesting. And I would love to know, and maybe this is putting you on the spot a little bit, but like with my future research, I would love to, you know, get community participatory programs in place, actually involve, you know, patients, especially patients experiencing pain and differential outcomes, you know, in their own care. And I'm wondering how some of your findings can potentially translate with, you know, having physicians become more empathetic around these issues, especially with something that is a chronic problem.
Yeah, Thank you for the question. And I want to take this back to give a perspective that people might not have the opportunity to hear otherwise, from a person who sees these issues very much from the patient perspective. But at the end of the day, I joke that when I finished my training in 2016, I graduated from 32nd grade, except it's not a joke. Like, it was actually 32 years of training in total. And as a resident, I worked 100 hours a week. 3 out of 5 weekends, I was on call, overnight Friday, and then Sunday from 8 to 8 or Saturday 24. And so when you're working that hard, and I never saw the sun, I was in Boston. So if you get to work at like 4 a.m. and you go home at 8 p.m., like, you never see the sun for like months. How empathetic do you think that you are to the needs of other people when your own personal needs are not being met? And so as I do this work, the grant that I just wrote, somebody was like, it sounds like you're clinician shaming. And I was like, no, I'm not clinician shaming. That's why I started off with that affinity group activity, to realize, like, just to destigmatize it, because none of us are trying to cause harm, that we're all doing the best that we can. And so to realize that it's not an issue of we're good or we're bad. I think most of us have good intention, but to realize it is a state of being a human being, and to get people off of being defensive right away, I feel like is the first step in this work, and kind of why I started it that way. But it's also realizing that as a clinician, it is really hard to take care of patients in medicine today. As a physician, you're essentially treated like an hourly worker at McDonald's, because usually the kind of like the point of where the money is made is like at a point on the totem pole where it's like, we must manipulate their behavior. We must make sure that they do these things and they get this many orders in and all of these things. You go to school for all of these years, and then you have business people essentially trying to regulate your behavior to make sure that you're seeing as many patients as you possibly can. And then you have people telling you you're racist and you're biased and you're causing harm. Like I think that, and then everybody wants to train you. So every other week you have like some 5-hour training, because people want you to train on, like, pick the flavor of the day, and they try to train on it. So I want you all to also think about that being the perspective of the clinician, because it's a really hard place to be in also. And there are all of these people with like demands, and it can feel overwhelming. Like, I actually fear that nobody is going to want to be a physician or a midwife or a nurse practitioner or anything for 30 years, because it's too much, right? And you even think about the pandemic and going to work and not knowing if you were going to bring terrible things into your household that would cause harm to your family. So I want to make sure that as I do this work, and I realize that as a representative of the healthcare system, as a clinician of myself, I recognize that we have things that we need to do. But I also think that I'm talking out of both sides of my mouth, I realize that, but that we have to be empathetic to clinicians, because clinicians have been to hell and back, and we're essentially asking them to be just shy of God, right? Like, none of us are perfect. We all fall short of the glory. And so I think, I'm trying to do the best that we can and take away the judgment, and give people credit for doing the best that they can with their life circumstances. And I think the beauty of Elevate, I hope, is that I don't think that didactic trainings tend to work in general, but yet I'm doing them. And it's because I think you need a framework, like you need something to hang that knowledge on. So yes, we're doing a ton of training up front, but then hopefully what we're doing is giving people the opportunity to apply it. That, you live out in West County, you grew up in an upper middle class household, you like never had a friend who wasn't the same race as you in your life. And now suddenly you're spending 30 hours with this group of patients who may not have any identity that is similar to yours. They're totally socially dissimilar. Yet at the end of the day, you realize that we have so much more in common than we have apart. And that 30-hour experience gives you the opportunity to see that. Like, that's my hope in terms of what's happening. So Camille, I'm sorry. I feel like that was a super roundabout, like both sides of the thing, but I do want you guys to see the clinician perspective too.
Thank you so much. And I realize that we are just now a little bit over time. We are not able to get to all of our questions. So I guess that means we're going to have you back at some point, Dr. Carter. So thank you everyone for being here. I know we had a lot of students and a lot of faculty colleagues here, and staff members from the Brown School here too. So I want to thank everybody for being here, but especially thank you, Dr. Carter, for your wisdom and your time. And just to say again that we really appreciate you and the work that you're doing, and wish you the best as you can continue on that road.
Thank you so much, Charlie, for having me. Thanks.